I am Dr. Alexandra Pepuano. I'm a geriatrician at Hamilton Health Sciences, professor of medicine at McMaster, and the chair of the RGP Central and executive director of the Geris Research Center. Delighted that we are introducing Dr. Dante Duarte today to these rounds. These rounds are a partnership between RGP Central and the Geris Center for Aging Research. We're really excited. Our division head, Dr. Dante Duarte, will be speaking on geriatric psychiatry. And he is the academic head of McMaster. He is a world leader in neurostimulation, and he leads a neurostimulation program at the Peter Boris Clinic. He's an assistant professor in the Department of Psychiatry and Behavioral Neurosciences at McMaster. And I'm really pleased to hand this off to Dr. Duarte.
Thank you so much, Dr. Papiano and the team, for inviting me to present today. Just going to share my slide. And I'm going to put on the presentation mode. Okay. So thank you so much again for having the opportunity to present today. So today I'm going to give you an overview about deep TMS in patients with depression, older adults. I have no conflict of interest for this presentation. I have some funding from the Center for Clinical Neuroscience, Peter Boris, and McMaster MIRA Institute, McMaster Institute of Aging. So today it's going to be a brief presentation, as you know, around 20-25 minutes. I'm going to give you just a quick brief prevalence of depression in older adults. I'm going to then talk about deep TMS, what it is, how we do to treat, what is a little bit of the mechanism, and we're going to go over the clinical study that we just ended. Actually, in July, we are presenting the final results now. I'm going to present the final results to you, and the results are we are like finishing the manuscript. So major depressive disorder, when we think about that, I think it's nice to have a little bit of a number in Canada. So the 12-month prevalence of major depressive disorder in Canada is approximately 3.2 million people in Canada. I took from the website today, so it's very up to date. It's around 80% of the Canadian population. So if we take the share of older adults in this population, we are talking about around 640,000 older adults with depression. If we then we know that 1/3 of patients with depression and older adults as well, they do not respond to our first-line therapies, even 1, 2, 3 trials of medication. So we are talking then about around 200,000 older adults are living with depression, what we call treatment-resistant depression. And some other source give even a more higher magnitude of the problem. Some sources, if you search, they're going to say, look, it's 20% the prevalence of depression in seniors, in older adults. So then we would be talking, 600, as I said, times 2, which is 1.2 million. And if you go to hospitals and long-term care, the estimate or the prevalence is even higher, which is double, is 40%. So as you can see, that this is a big issue today. And we are here to trying to work on some alternatives for these units. How about to optimize treatment with augmentation or switching agents? So some of you may ask, okay, why 1/3 is refractory? How about we try new medication? How about we add a new one? Would that person respond to the treatment? Perhaps we are not trying harder enough. Perhaps we are using just 1 or 2 agents. So then came this study, a very nice study optimum study. Some of you may know. It was published in 2023. It's a pragmatic, open-label, randomized clinical trial. They compared the effectiveness and safety of an augmentin versus switching agents for depression. So I'm going to explain a little more. Pragmatic in this case means the patients, they have had 2 failed trials, and then they've tried the augmentation. And also patients, they were on their standard of care. So let's say a patient of mine was on duloxetine. So the patient could continue to be on duloxetine, they would then end. So look what they've done. They divided the population, the sample size, in 3 groups. And it's a huge sample size because it's older adults, right? So as you can see, group 1, they did an augmentation with aripiprazole, as you can see in pink, the first graph, the step 1. The group 2, they added bupropion to whatever medication the patient was on, okay, the participant. In group 3, they switched it. So let's say, again, a certain participant was on duloxetine, they then switched it to bupropion. And sample size it's considerable for older adults, as I said. So it's about 200 in each group. So what they found is that, yes, there was some benefit. The primary outcome was psychological well-being. It was a scale that measured psychological well-being. The secondary outcome was depression and also safety. There was some improvement, 4 points, as you can see, modest, but yes, they had some improvement. And if they have failed to those 3 groups, they would try lithium augmentation as a second step or switch to nortriptyline, okay? So these are the findings. I invite you to read the paper. It's a very nice paper. But what I wanted to call your attention is to the secondary outcomes, which are what? Number of falls or side effects, which is impressive. So as you can see, this is a 12-week study. So basically, patients were exposed, participants. I keep saying patients, but it's participants, right? Because it was a research study. They were exposed to those agents for 10 weeks, 10 to 12 weeks, so 3 months. Look how many of these these participants, they had a fall. So basically, 0.33 per participant in the aripiprazole group, half 0.55 of falls for the bupropion augmentation group, and switch to bupropion around 4.4. So what that means, this is a busy table, but that means what? The total number of falls in the aripiprazole group was around 70 in 3 months only in a population of 200. So the bupropion augmentation was around 114. So total number of falls in 3 months. If you go down here, adverse events, total number of adverse events, it's more than 500, the first group, second group. And the rate per patient was almost 2.2. So the take-home message of this study is saying, yes, if we add more medication, we perhaps can improve quality of life modestly. But in what cost? The cost of the side effects here, in my opinion, are a high burden. So that's why I think we need to offer alternatives to our public, to our patients, right? Because it's either medication, psychotherapy, mindfulness, meditation, and ECT, electroconvulsive therapy. So we need to find an alternative there. So that's why we have today TMS. TMS stands for Transcranial Magnetic Stimulation. And we also have Deep TMS. Deep TMS stands for Deep Transcranial Magnetic Stimulation. These are the 2 devices most commonly used. So basically, what transcranial magnetic stimulation does, it is a magnet, as you can see, but it's impulses. So you have, several magnetic pulses per milliseconds, and each pulse has 1.5 to 3 Teslas. What that means, each pulse has the strength of an MRI, like an actual MRI, which is a 1.5 Tesla MRI. The difference is it's per milliseconds. That's why the brain and the tissue can support and can receive the stimulation. So basically going through your skull and enriching your brain, some regions of your brain, you can then activate the brain networks. You can increase function, you can increase excitability of those underlying networks. And this is one of the mechanism of action. There are others, but again, it's we can discuss that later in other meetings or later on. So basically, as you can see here, we have, this is a heat map, which means it's an electric field map. It estimates where the magnetic field is going through your brain. And as you can see in the third row, the deep TMS coil, it gets much more red and orange, which means it targets bilaterally your brain networks, increasing the heat map, which means increasing the magnetic field underlying. The traditional TMS in the second row, it also has a good effect. I mean, a good impact, as you can see, but less so than the deep. So what we have so far in Canada, we have health approved stimulation in Canada, which is H1 coil, which is that design, which is a coil that is Health Canada approved for depression. We have the H7 coil. As you can see, H1 targets more the frontal region of the brain, like prefrontal. We have H7, which targets anterior cingulate cortex, more the medial part of your brain, as you can see the design. And you have an H4 coil called, it's for smoking sensation. The H7 is for OCD, obsessive compulsive disorder. All those three coils are Health Canada approved for those indications. It's not off label. So then we asked ourselves, how about we run a study that we're gonna compare the H4 coil, which is the coil that targets the insula, which is Health Canada approved for tobacco. How about we use that coil and the H7 coil, which is the cingulate cortex coil for the patients with OCD, but let's try to deliver those stimulations in patients with depression, older adults. So we then developed this study called DIVINE study, Differential Feasibility and Tolerability of Deep Repetitive Transcranial Magnetic Stimulation for Depression in Older Adults. This is a pilot study. Our population, as you can see later, I'm following the PICOT guideline, P as in population. So our population was older adults, 60 plus, with treatment-resistant depression. Our intervention, it was deep TMS. We had a 1-1 ratio to two groups. One was H4 and the other one H7. I'm going to explain the next slide why we think that exploring other brain regions could be useful for depression. We were comparing both coils. Our first outcome measure was feasibility outcome because it's a feasibility study. Our second was reduction in depression measured by HDRS. And we also measured brain waves through electroencephalography. We measured before, each week, and after. So the treatment was for 4 weeks, every day. Patients would come every day for 4 weeks. We measured those outcomes at baseline, at the end of each week, at the end of the stimulation session, which was week 4. And we also measured at follow-up in 2 weeks. Why we thought that going to the insula with the H4 and targeting the cingulate cortex with the H7 could be used for depression. Insula, it is a hub. It's known as a hub in our brain that is involved in cognitive and affective control processes. It has several connections, as you can see here. Basically, the insula connects with all basically most of the brain regions, particularly thalamus as well down. There are several studies suggesting that patients with depression they have a hypoactivation or a dysfunction also in the insular region. So that was the rationale underlying why we're going to target insula. The rationale why we are going to target the cingulate cortex, it's because the cingulate cortex is part of the what we call cortical limbic system. It has connections with the prefrontal cortex, and it also has connections with the more limbic peer system, which is the amygdala, the hippocampus. So it's a well-known region that it's associated with depression. Again, when it is not quote functioning well. So that's why we designed that study, as I said, instead of focusing on all the brain regions, we focused on insula and prefrontal cortex with H4 and the cingulate cortex with H7. So our primary outcome was protocol completion. We were, trying to measure how many patients had dropped out, the retention rate, safety was a main point in our study, because this is the first study worldwide to test this intervention in patients with older adults with depression. So, and technically seizure is a rare side effect. We don't want to write that it's something that we need to measure. Tolerability as well, as you know, is a helmet, right? And then you have magnetic field, so you can feel like some sort of it's like some clients, they say it's a woodpecker. So just to give you a perspective of some clients. Our secondary outcomes, we measure depression, we measure anxiety, we measure sleep quality, we measured cognitive performance. We did neuropsych testing before and after. We also measured, as you can see, we have a dry EEG, which is electroencephalography, and we measured brain waves to run power spectrum analysis, pre and post. I'm mindful of my time. Okay. So these are the results so far. Not so far, I'm sorry. These are the final results, but we are publishing these results. So as you can see, the blue is the H4 coil. Participants assigned to receive the treatment with H4, which is the stimulation of the insula. So as you can see, just a second here. Yes. So we had a reduction. So they started at 28, 30 at the Hamilton scale, which is considered severe depression. And at the end of the follow-up, like this is the endpoint week 4, the midpoint. So they went down to 11, and to the follow-up was around 12 for the H4. For the H7 was around 11 as well, 11.9, and then around 10. So both groups, they reduced by about 65%. So they had a response. They had a reduction of depressive symptoms in around 65%. So I have to assume, and to be honest with everybody here, that was impressed. We were impressed with the results. I wasn't expecting this amount of results. You can then say, yes, but you didn't have a placebo arm. Yes, and I have to agree with you. There is no placebo arm. I can't say this is not due to placebo only. But being very honest, 65% only due to placebo, it's a great placebo effect if it's only placebo. And again, this study is not designed to test efficacy because it's not well powered, because it's a pilot study. But even though we are not designed, we did find this significant result. Just a second. Yeah. So when we use like a concept of clinically meaningful reduction, which you took from this researcher, we matched our scales with instead of a Hamilton 24, we matched with a Hamilton 17, following Rush et al. And the calculation is that if you have a reduction of 6 to 7 points on the HDRS, it's called clinically meaningful reduction of your symptoms. If we take that concept, we have about 95% of the clinical meaningful reduction, because 18 out of the 19, that was missing one participant because we didn't include at this time of the analysis. It had a clinical meaningful reduction of symptoms. So in terms of the feasibility and safety outcomes, we had two dropouts. One was a physician. He was dizzy. He had a lot of anxiety and he had some dizziness, but according to him, TMS made him more dizzy. The second one dropped out the first week. We don't know really why he dropped out because he wasn't experiencing any major side effects. 4 patients reported mild headache and neck pain, it's relatively common when you have a little bit the magnetic field on your head, and also the neck pain. But they did not drop out, and the headache goes usually is transient, and after the first week it goes away. We always ask clients to take or like an over-the-counter medication, and no serious adverse event. So we didn't have any major adverse event that could terminate the study, or we had to report to the high red. So I guess for presentation today, I'm getting close to my time. Is take home messages. My last slide. Deep TMS is a viable treatment option. Why? Because as I presented, most 30% they don't respond to medication. Forget. Okay, what to do with those 30%? So let's offer them electroshock, ECT, but part of them are not severe enough to have ECT, or they don't tolerate side effects, or ECT is too much for them. They don't want ECT. So these are perhaps viable options for the TMS. A second point is also, let's say those patients were severe enough to have ECT. They required ECT, but ECT has a maintenance phase. Otherwise, the relapse rate in 2 years could go up to 60% if you don't have maintenance. So how about perhaps offering deep TMS as a maintenance instead of exposing patients to ECT as a maintenance? And need a broader access to TMS. I'm advocating for our institution to purchase a deep TMS device. We have one at PVCAR just as a research. It's a research device. I'm advocating for us to purchase a deep TMS to offer to the public. Thank you so much. Thanks again, Dr. Papiano. Thanks again to the team. I'm open for questions now.
Excellent. Thank you so much, Dr. Duarte. Very interesting. Also want to thank Anjali and Jen from JERIS and from RGP Central for organizing today's. We have a question from John, which was going to be my question. John, that's a great question. Who is eligible? What would be exclusion criteria? Is it covered by OHIP? And how long do the benefits last?
So eligible for the research study or for the clinical? If it's clinically.
If you had a clinical machine.
Oh, clinical machine. So most of patients are eligible. The exclusion criteria are implanted medical device, like those implanted medical device. If you have, like, say, implanted like aneurysm clip, if you have had seizures, pacemakers is still, if it's not MRI compatible, pacemaker is a contraindication as well. So these are the main contraindication. No, I'm sorry, not contraindication, exclusion criteria. So the effect, how long does it last? It's hard to tell. It's like ECT. 50% may never have another depressive episode in the future. 50 to 6% gonna have it. We can't predict how much the effect is gonna last. It's individual. It's an individual basis.
And in terms of anxiety, is it the same, or in terms of effects? Or, when I was really struck by the high falls rate, obviously as a geriatrician and somebody focused on osteoporosis, that was a concern.
Yeah, exactly. It's medication. Yeah, I was, when I read this paper, I was really, really curious as well. So the TMS helps with anxiety if the anxiety is associated with the depression. If it's like a pure GAD, like a generalized anxiety disorder, it's not an indication. But if patient has anxiety plus a little bit of depression or both, then could be a good treatment. I wouldn't suggest for anxiety only. For also obsessive compulsive therapy, obsessive compulsive disorder, you can try the H7 coil.
And so is it covered by OHIP right now?
So our hospital offers in a compassionate base. So there's no cost for that. OHIP doesn't cover, it's free. The hospital offers that. So the patient don't have to pay anything. In terms of the healthcare provider, there's no OHIP billing for TMS. The nurses, they deliver the procedure. We as physicians, we do an assessment at the beginning. We make an assessment at the midpoint, and we also assess the patient at the end. But it's for free in our hospital at St. Joseph's. Yeah.
So how would we refer? Is this a ongoing clinical trial or that we?
No, yes, we have a TMS service. We have 2 TMS device. It's not the deep TMS, but we have the traditional TMS. You can refer to the Connect, like a Connect referral. You can refer to the mood disorders program and ask for TMS. So they're going to refer to us. We have 2 devices. I work at this service and it's available for the public, for the population.
Okay, great.
But not the deep one, just to be clear. Yeah.
So the deep one seems to have the more promising results.
I think, Dr. Papagliano, the deep one is particularly for us who are geriatricians and geriatric psychiatrists. Unfortunately, our patients' brain are a little atrophic, right? So they're a little far away from the skull. So we want a technology like a TMS technology that goes a little deeper. So that's why I think for geriatric population, deep TMS makes more sense. But if you go to the research studies, they put all together, right? They do adults. Yeah.
And in terms of diversity of participants, was there different age groups, different racial backgrounds?
So the diversity, yes, different, exactly. Racial backgrounds. There was a diverse population. We had a diverse population. I can share with you when we publish the findings. We have a pretty significant demographic. I just didn't present here because of the time.
Great.
But I can share with this group when the paper is published.
Yes, and that was from from Jane McKimmon Wilson and from Dr. George Ioannidis. How many adverse events did you have? You mentioned headache.
Yeah, we measured adverse events in every visit. Every research visit, we measured an adverse event. We didn't have. Yes, we asked about falls. We asked about headache, falls, dizziness. There is an open question as well. Is there any other adverse event that you can? We ask about mood swings, falls. What else? Yeah, it's an adverse event scale, right? And we measured baseline after the first session and after each session. So we measured adverse events for across the treatment. So all the 4 weeks. We didn't have any severe adverse events. We had headache in 4 patients. In the first 2 weeks for 4 patients, they reported mild headache.
All right, well.
And we're going to publish those results as well, the table.
And we'll put the link on our website, so keep an eye for it for the future. Thank you so much, Dante. And our next presentation will be by Dr. Heather Keller, and she will be presenting December 2nd on nutrition and dementia. Thank you, everybody. We had over 44 participants today. Great bullet rounds. Thank you. That was very interesting and exciting options for older adults in the future.
Thank you so much. Thanks again for everybody.